A review of gender identity services for under-18s in England says they've been let down by a lack of research and remarkably weak evidence on medical interventions. The report by the paediatrician Hilary Cass also says professionals have been afraid to openly discuss their views because of what she calls the toxicity of the debate around gender. She argues that children questioning their gender identity should have a holistic assessment, including screening for conditions such as autism and mental health issues. NHS England says it's already making changes.
Thank you. It is 27 minutes to 8. The conclusions of the long-awaited Cass report into gender medicine for children contains one simple, devastating sentence that will echo around the medical world. For most young people, a medical pathway will not be the best way to manage their gender-related distress, Dr. Hilary Cass says. She adds that children must be seen as a whole person and not just through the lens of their gender identity. Instead, young people with problems like anxiety and depression were passed too readily, she says, to the Gender Identity Service at NHS England. And those young people have also been let down, she says, by a lack of research on the long-term impact of giving hormones to people at an early age. To this day, puberty blockers are still being prescribed by the NHS in Scotland and by private clinics. Dr. Cass told me it is girls, often very troubled girls, who are the focus of modern gender medicine.
There has been a significant change in the population of young people over the last 10 to 15 years. So about 15 years ago, the service was seeing perhaps 50 predominantly birth-registered boys in childhood, and over the last 10 years or so, it's switched to over 3,000 young people, and it's mainly birth-registered girls presenting in early teens, and as you say, often with quite complex additional problems.
Were those additional problems addressed properly, in your view?
Well, no, because of the toxicity of the debate. They've often been bypassed by local services who've been really nervous about seeing them. So rather than doing the things that they would do for other young people with depression or anxiety or perhaps undiagnosed autistic spectrum disorder, they've tended to pass them straight on to the GID service, and they then ended up at the back of a very long waiting list because GIDS wasn't really able to cope with the rising numbers and the complexity of their presentations.
But when you talk of the toxicity and them being passed on why? But for fear of being accused of being transphobic? What was the reason?
Well, we did a survey early on, and I expected that clinicians would say we don't have the time, we've got very big backlogs. But the things that they were really worried about is no guidance, no evidence, and no training. And as well, as you say, worrying that if they did the usual sort of assessment that they would do for other children, they would be not necessarily accused of being transphobic, but not immediately affirming the young person in their gender.
Is there evidence that puberty blockers are safe to use?
No, we don't have good evidence at the moment. They are absolutely safe to use for a completely different set of children, which is children who go into puberty too early, and they're also used for adults with certain kinds of cancers. But this is a novel use, using them to arrest puberty, and we don't know the long-term impact of that on brain development because there's a rapid period of brain development in adolescence, and we also don't know if it changes the trajectory of somebody's gender and psychosexual development.
Is it normal in medicine for something that is so unknown to be used and used so much in one area?
Well, the team did start off by doing a clinical trial, but the point at which practice diverted from the evidence was when they went on to routinely prescribing before the trial results were available, and also prescribing to a wider group of young people.
Why do you think they did that?
They clearly felt that they were doing the best for this group of young people, and obviously they would have seen some young people who they felt were improving. But we do know once the study results were released that some young people were improving, but some young people were getting worse. And that's not surprising because their broader range of problems were not being addressed. It is unusual for us to give a potentially life-changing treatment to young people and not know what happens to them in adulthood. And that's been a particular problem, that we haven't had the follow-up into adulthood to know what the results of this are. That's the reason why I've said that we must improve the research base here. So that means finding out what happens not just to the young people who go onto puberty blockers or on masculinizing and feminizing hormones, but also those who don't go on a hormone pathway. We need to know how psychological therapies help as well.
You talked earlier about the initial stages of children seeking treatment and people not wanting to, GPs presumably initially not wanting to get involved, and the wider mental health staff that there are. What was there also, in your view, and according to your report, a pressure on Tavistock and on the gender identity clinic in particular that they were willing to accept from outside that pushed them down a particular route?
Yes, I mean, I think there have been all sorts of pressures on everybody involved, and I think people at the front line in whatever setting felt that they were doing the right thing. I mean, everybody I spoke to passionately believes that they're doing the right thing. Nobody's setting out to harm children. But I think one of the difficulties for the Tavistock was when there wasn't any other centre that was providing the same treatments in the country, you don't have peers to talk to, and so you then there's less reflection, perhaps.
I want to play you a clip, if I may, of a trans woman who we've talked to in her 20s now about the delay that she feels did her real damage when she was younger. Let's hear it.
All in all, I spent 4 years on waiting lists to be seen by an NHS specialist. It was incredibly frustrating. And the period between being told that, oh, we're not going to see you before your 18th, and being referred on, and then me gaining private healthcare was an incredibly dark period in terms of my mental health. It was the lowest I've been during the course of my transition. Because of simply me having to wait as long as I did, I went through pretty much the full course of male puberty. During that time, I felt incredibly uncomfortable. It never felt like me. I always felt wrong. I didn't feel like I could accurately be myself. And that's purely because I had to wait so long to gain any semblance of care.
What's going to happen, Dr. Cass, now to the hundreds, possibly thousands of children who are now in that position and who've been told, certainly on the NHS in England, there is no chance of puberty blockers and, well, nothing much happening?
Well, first off, I'm really sorry to hear that story because it is heartbreaking, and I know there are many other stories like that. In the first instance, NHS England has put some additional resource into support local services to at least be doing an initial assessment.
Is it enough, do you think?
It's not about the money, it's about the workforce. And a huge part of this is we have got to help clinicians from all backgrounds realise that they do have the transferable skills to see these young people. And I know there are massive waiting lists for mental health in general, but this particular group of people has been disadvantaged compared to other similarly distressed young people.
The point being, I suppose, as well, that the things that will be offered might not include or might be an effort to avoid the kind of things that would change a person's body forever.
Yes, there is going to be a small number of young people for whom a medical pathway is the right pathway. And in many ways, the more we can address the wider problems for some of those young people who are not going to go on a medical pathway, the easier it will be for us to ensure that those who are going to need a medical pathway get onto that specialist track sooner rather than later.
There are still private clinics, aren't there, that are able to prescribe puberty blockers, should there be?
Everybody should be getting the same standard of care, and I do have concerns about private provision, which is not providing the level of assessment that I'm recommending in the NHS. I fully understand why parents have felt that going down that path is the best way to serve their children, particularly just hearing that harrowing story of a 4-year wait. We have asked NHS England to provide advice to families about what it means if they go down a private route in terms of coming back into the NHS later.
Has this been a medical scandal? Is that the right way to see it?
I think that's for somebody other than me to make a judgment on. I've just been focused on the best way to move forward, to get a holistic package of care for these young people, to get them back into a more mainstream form of mental health and paediatric provision, and to get the evidence that we need so that they can make informed decisions in the future.
Dr. Hilary Cass, thank you very much for talking to us.
Thank you.
And just to say, the NHS have been in touch with us and said that they're making significant progress towards establishing that fundamentally different gender service for children and young people. They've written to local NHS leaders, they say, to ask them to pause offering first appointments at adult gender clinics to young people below their 18th birthday.
It is 16